So Varun is from Mumbai. You are there in my panel previously also. Thank you. Can we have extra chairs? Yes. Nikhil Khatri ने बड़ी छतरी बना दी है. So we have got all these panels. So at the outset, I would like to thank Isar. I would like to thank Sunita, Dr. Milpatki for giving me opportunity to be there on this platform, and probably I am the last person. So after this, you can have a very good banquet with dance and dine. Welcome all panelists. Today we are going to discuss something regarding ultrasound and infertility. So we are in Pune. So welcome to Pune. Pune is land of Rajneesh. We all know the moment child is born, mother is also born. She is there. Mother is something new. So we have to salute our mother, and how beautifully everything is arranged by Almighty. When child borns, Monica ji, mother is always there. Father may not be there. Sultan may be fighting somewhere else, but mother is always ready to take care of that. With the blessings of mother of mine, 3 books written by us is recommended in Royal College. Atlas of Fetal Echocardiography and IVF Made Easy at Birth for 2nd edition. I am editor-in-chief of 2 journals, so those who want to publish their work, they can give me, because with this I have got 114 publications on working. Recently I have got opportunity to take interview of Professor Herman Tournay in Ashray, and you can scan this for YouTube channel. You all are doing ultrasound, madam. Okay. How ultrasound is useful in your practice to enhance the fertility surgery? We are starting with Varun. He is the first person. Okay. Because my topic is use of ultrasound for enhancement of fertility preservation surgery. So, okay.
I'll introduce by myself.
All faculties, when they will go to the question, they will introduce themselves. Okay, so you are Varun.
I am Dr. Varun Shah from Mumbai. Sir, to answer your question, that now our practice in fertility is such that each and every patient undergoes an ultrasound.
Yeah.
And in that you invariably find, as Dr. Chandralula said nicely, so many pathologists.
Yeah.
As a fertility specialist, your job is to decide whether something requires surgical intervention or not. And most likely, there is a possibility that ultrasound will help you screening the places where you do not want to touch the surgery.
Okay. Dr. Monica, introduce yourself and what is your thinking that ultrasound will enhance your fertility surgery with ultrasound?
Right. I'm Dr. Monica Singh from Bhopal, and thank you for inviting me as LMF. So I definitely would like to use a transabdominal and transvaginal probe both before doing any sort of fertility enhancing surgery on my patient. I'll use the transabdominal probe with a full bladder so that I get a panoramic view of the pelvis. Immediately I'll come to know the uterus position, size, shape, adnexa, any peritoneal fluid, any other abnormality, and I get an overall impression. And then this will follow with a transvaginal scan, wherein I would like to specify my findings to the version and flexion of the uterus, the mobility, the sliding sign, the adnexa, the ovaries, the pouch, any collection, because here naturally the transvaginal probe will give me limited penetration. It will give me more resolution but limited penetration.
So now, according to all panelists, ultrasound became a stethoscope for us. When we started our practice, ultrasound we are using in particular cases, or out of 100 patients, 3-4 patients are going for ultrasound. Now the scenario has changed. 3-4 patients are going for routine examination. We can't live with ultrasound. Everybody agrees. We can't live with ultrasound in this era. Doctor, you had lived with without ultrasound since long in your earlier practice, but nowadays without ultrasound nobody can live. So it acts as a stethoscope. And it is very rightly said by Dr. Monica that your perception of looking towards uterus adnexa is going to be different when you started infertility practice. Otherwise, what we routinely will do uterus, both ovaries, okay, forget it. Now we will see uterine pathology, uterine vascularity, the ovarian volume, uterine volume. Chandralula has rightly mentioned that ovarian volume uterine volume before implanting the embryo, it is a very good thing. And we are doing it. Madam, your take on ultrasound in fertility enhancing surgery?
Myself, Dr. Akriti, I'm from Dehradun. I think ma'am has beautifully enumerated the basic things we actually see when
See
we
in
do
the
an
ultrasound.
And besides that, sir said that you have to evaluate. Yeah, the second thought comes evaluation of the pathologies. So we start with the uterus. We see any deviations in the endometrium, any myometrial texture that is abnormal, presence, rule out fibroid, adenomyosis, or polyp, for example. So endometrial pathologies are examined. Other than that, we also see if in case there is abnormality of the tubes, visible signs of hydrosalpinx if any evidence is there. Then we move on to the ovaries. We find any abnormality in the ovary in the form of polycystic ovarian morphology, or if in case cysts, as sir had enumerated so many beautiful pictures of hemorrhagic cyst,
Yeah.
presence of an endometriotic cyst, multiloculated complex cyst. So it's a very good place where we actually see all these things. Besides that, I think adhesions, something which we can pick up in even in an ultrasound. If doubtful, also go for a saline salpingography and proceed with the surgery of hysteroscopy. So definitely it helps us in deciding the plan of surgery subsequently before any procedure we go ahead with.
Yes, madam. What are your take on pre-operative planning, the use of ultrasound?
Yeah, thank you. I'm Dr. Vaijayanti from Hyderabad. So today we had a wonderful lecture by Dr. Chandra Lulla looking into the different aspects of how as ultrasound helps us with identifying pathologies and stratifying them. So when we talk about pre-op surgical planning, ultrasound is very, very important. We are now talking into the different different consensus groups. When we talk about adenomyosis, we have the MUSA consensus group, which has put the criteria. And again, when we look at fibroid, we have got the FIGO classification and the STEP W, so that we can plan how we are going to approach the fibroids. And if the fibroid volume is more, we need additional investigations like transabdominal ultrasound, MRI mapping. So fibroid mapping is very, very important prior to our looking into which is the mode of surgery which we are going to approach, which is the mode and what precautions we need to do, particularly in a fibroid if it is a submucous fibroid and we are going to go ahead with the resection. Similarly with adenomyosis and similarly with endometriosis, these days we talk about mapping of endometriosis also.
Yeah.
So we talk about the deep endometriosis, endometriomas, along with in case we have adenomyotic lesions, how we are going to approach. All this is very important that we have a mapping prior to the plan.
So everybody agrees that ultrasound give you a roadmap, that where you have to plan your surgery. Now, madam, you have got this many fibroids with you. These are the slides which shows multiple fibroids, and this will help you in your fibroid surgery, or you just want to just pick in your laparoscope and you want to do surgery.
Hi, I'm Dr. Sunita Arora from New Delhi.
Yeah.
So, first of all, I would like to say that if a gynecologist and fertility specialist knows her scans well, then half the job is done.
So now we have to become sonologists also. So thanks to all sonologists, Chandralula who has taught us in 1994
but
that
we
have to
cannot
become
negate
gynecologists.
the role of
No, they are
sonologists.
they are the pioneers.
Yeah,
they are the big boss.
Yes,
they are the number one
always
branch,
needed.
madam.
They are always needed. So as far as fibroids are concerned, the location of fibroids,
Yeah.
that's fibroids mapping is very important.
Number one,
In
location.
taking- Yes, and then the size of fibroid.
Number two, size.
Then we have to look at the number, we have to look at any degenerative changes if there are
Four.
in the fibroids. So this is, basically to assess whether a particular fibroid needs to be addressed, if at all or not. Because there may be pea-sized fibroids sitting there, they may be multiple in number, we need not address them. But any submucosal fibroid always needs to be addressed when, especially it comes to fertility. When it is a case of recurrent implantation failure, then even intramural fibroids are to be looked into with a deeper thoughts. Because sometimes collectively, if the size of all the fibroids which are purely intramyometrial and patient is not conceiving and there is no other apparent factors, sometimes we have to take a decision for operating on those fibroids. Then the approach to these fibroids,
Yeah.
whether your hysteroscopy,
Scopically or laparoscopically.
yeah, that is one. And second is, can this patient need a second sitting or am I anticipating it to do in one go?
One go.
So that's another thing, fibroid protruding towards outside, it is purely intramyometrial coming towards the cavity or not.
Anything more will help ultrasound for removal of fibroid? Madam, missing one of the things.
She has, I'm Brigadier Lele, I'm from Army Hospital, Delhi.
So you are not into ultrasound.
Pardon?
You are not into ultrasound. You are doing ultrasound by yourself. No?
I am.
Yeah.
So, in that.
So what one important thing madam has missed in this entire answer? With ultrasound, you can do one more thing. Before mapping, one more thing, Chandralal has elaborated different flows, 1, 2, 3, 4, 5, 6.
It can tell us the position.
Vascularity.
Vascularity, yes.
Number one, vascularity, and from the feeding, where the feeding vessel going. Because usually one fibroid has got one or more feeding vessels. So sometimes in a bigger fibroid, if you know where the water is going, so if you coagulate that feeder vessel first, then fibroid removal will be very easy. And there ultrasound is helping. And we have got different modalities of flow: slow flow, ultra slow flow, power Doppler flow, color Doppler flow, unidirectional
I
flow.
think when it comes to the vascularity of fibroid, then overall vascularity is also important.
Overall vascularity, because sometimes the fibroid which is located near to the uterine artery, and it is a big fibroid. So you see the vascularity will be very much. So at that time, if you want to remove that fibroid, you can ligate the uterine artery by shoelace technique. You can ligate or you can clip the artery. So it is very easy. And this is only ultrasound can help you. Because ultrasound will guide you where the vessel is going. And because of unidirectional flow, double directional flow, power Doppler, you can know which vessel is there. So you are using this modality in mapping the fibroid to see the vascularity also.
See, I would, for mapping the fibroid for vascularity, I would go for MRI or
Okay.
CT guided.
MRI give you the numbers. For vascularity, you have to go for
Vascularity, I will
MRI.
go for CT rather than ultrasound. CT guided will be a better picture because I will have a definite area from where it is going, and the same thing I can extrapolate when I am operating.
How many of you are agree that MRI and CT scan is much more helpful than ultrasound? How many are there for ultrasound?
See, but when you talk about the artery, when feeding vessel,
Feeding vessels is very well seen on color Doppler setting.
on color Doppler, it is
And if you
dynamic.
want to do MRI, then you have to go
It
for
is-
MR angio.
it
That
is-
is much costlier thing.
It is dynamic.
Hey, excuse me, Nilesh, can we have 2 mics more? Mic people, can you give me 2 more color mic over there, if it is possible?
One more thing I wanted to add, Manish
Yes.
sir,
Yeah.
that sometimes when we introduce the scope for laparoscopic myomectomy, sometimes that bulge is not there.
Yeah.
You know, you don't, it might be a deeply seated intramural myoma, 4 centimeter, 4.5 centimeter. You want to know precisely where to place the incision. There in the fibroid mapping is very important because
And
you know
number one-
exactly.
Number one, same thing. Suppose I am doing myomectomy, and once I see the uterus is very well seen, but there is nothing like myoma is seen on the uterine cavity once you peep into the scope. At that time, you use your transvaginal probe to see the fibroid, and on this transvaginal probe, you can inject your vasopressin directly. You put transvaginal probe inside the uterus. Laparoscopy is already there above. With that, you can map your fibroid very well, and with that mapping, if suppose this fibroid is not visualized in the laparoscopy because it is deep seated, but it is very near to the cavity. Now you plan laparoscopy, you can plan hysteroscopy also. That depends upon your expertise, how you are able to do with this fibroid. But my rule, how ultrasound is useful. So at this juncture, I will put my transvaginal probe inside the vagina. I will see there is a fibroid. Then I will take my injection needle. That needle is also that is acoustic, so I know that my needle is going there, and on that I can cut that fibroid. So use ultrasound intraoperatively also. Fibroid mapping is very good, and if you know that how many fibroids are totally disturbing, there are 18 fibroids, but all 18 you can't remove at the single go. If you are expert, you can remove 90, 20 fibroids also. But for sorry, For mapping, for this juncture, ultrasound will guide you that this fibroid are must, this will do, and this I can go it at the time of cesarean section. Because so many big fibroids, they are subserosal. We are doing cesarean myomectomy also. It is also very easy. So you can plan that this fibroid I can remove at the time of cesarean section when she become pregnant. How many of you are doing cesarean myomectomy? During the time of cesarean section, you remove the myoma. It can be done, and it can be very well done because planes are very good. Uterus is big, and suturing material you have got now got barb suture also, you can suture the same barb with them. Madam, would you like to add something?
Yes, good evening everyone. I'm Dr. Mahima Nagpal from Delhi.
Yeah.
As a fertility expert, I would always not overdo the surgery. My
Yeah.
whole idea is always to save the uterus.
That is
and
Hippocrates has
actually,
already told us,
even if
never
there
do
are-
harm to our patients.
Yeah, never.
So that's why I know that which are the fibroids are must removable. Because I know I can remove all the fibroids and I will say only small sopari sized uterus, that it doesn't work. So I have to keep subsequent amount of substantial uterus to be there to make her pregnant.
Yes, exactly. So I think ultrasound really helps us pre-operatively to do the fibroid mapping, endometriosis mapping in our mind, and we can counsel the patient accordingly whether we need one sitting, we need two sitting, because
Yeah.
I think it really helps in counseling the patient. We should have an ultrasound available intraoperatively as well.
As well.
rightly said by-
It is a non-invasive, so many times you can do it.
Yes, and I think for deep-seated structures, it really helps intraoperatively and post-operatively also. To check the cavity, whether we have sutured the cavity well, and how good it is looking for our embryo transfer. I think it is
So
really helpful.
ultrasound helps us in a very good thing. Now we will start with ovarian cyst, madam. Any ovarian cyst you will see on ultrasound that can be removed, or that should be removed, or you have got some cutoff in your mind. If suppose cyst is 3 centimeter, 5 centimeter, 10 centimeter, septate, without septate, endometriotic, dermoidic,
Less than 3 centimeter, if it's a clear cyst, I'm not even thinking about
follicular cyst like this, you are not touching.
No, I'm
We are
not
giving them
touching.
the progesterone medicine, sir.
We will not even there's many cysts which may appear bizarre are corpus luteum hematomas.
Yes, with ground glass appearance or honeycomb appearance.
And,
We can see that it will go after in the next
Such
cycle.
cysts, we should not. What Dr. Chandrullah said, that whenever you have a simple cyst with some solid component,
Yeah,
these cysts one should think about removal.
Yeah.
Provided we do.
we have got POETA classification. We know that this is benign or this is malignant. That is different. But for a fertility person, now, sorry, we are not talking about malignancy. There are simple cysts, simple looking cysts, no solid component, but septate cyst. Cyst of 3 centimeter, follicular cyst, forget, everybody don't want to do it. But cyst between 3 to 5 centimeter. Cyst has got endometriosis. Now the scenario change. Yes, Varun.
Sir, in my practice, unless it is a endometriotic cyst, which
Okay.
I confirm,
Hmm.
I typically don't go for cystectomies.
Okay.
And most of the time, it can be managed simply through observation or through simple measures like estrogen plus progesterone,
Oh, so it
and it would work miraculously well.
Miraculous. So
In fact, so many people do cyst aspirations as well, and which I personally feel is a futile exercise because it can reoccur again and would give you the same headache. Might as well just observe it; it would go.
So 3 to 5 centimeter we can observe, but now cyst become 5 centimeter, 5 to 6 centimeter. Monica, madam.
Still nowadays, endometrioma cystectomy has come under the scanner
Okay.
because there is a school of thought wherein try not to do a cystectomy of a clear-cut endometrioma, even if it is 4.5 centimeter. There are definite indications.
So,
Either it is,
they are restricting up to 4.5 centimeter.
No, there is no definite size criteria
Okay.
now, sir. Either it is growing very fast and obstructing the way of your aspiration of the follicle,
Okay.
or it is causing pain to the patient.
Yes. If there is dyspareunia,
Yes.
dysphagia.
So these two are the only indications wherein you will remove. Otherwise, nowadays most IVF specialists are preferring to stimulate the patient with the endometrioma in situ and
So
doing the
they
cycle
have
like
got,
that.
because they have
Yeah.
got 2 ovaries. Now one ovary has got endometrioma, second ovary is very good. So you can stimulate that second ovary. Yes, madam. Would you like to add something?
Sir, also that since we are talking about fertility here, so obviously the patient has come to us, so we need to see the parameters ovarian reserve,
Yeah.
AFC count, and also the AMH. So
Okay.
how long is the history of infertility? That also.
And how many doctors he has visited before visiting you?
And true.
How many pillar posts he has
Very,
put
very true.
their files?
So those things also will be a part of your history, and that would also help you decide whether to go for a surgery or not.
So we have to proper take the definition of history. That is study of past and light of presence to have good future.
Actually, the endometrioma surgery or the endometriosis surgery should be one final and best.
So that is
And preferably do that
will
surgery
come
after the obstetric career of the woman is over. That is the message.
Yes, madam.
So,
Yes, both. Everybody wants that.
so I will agree with Dr. Monica that surgery on endometriosis has to be taken with pinch of salt
Pinch of
when
salt.
the patient is coming to me.
Why
for
I am
fertility
pouring this question? Because in every center there are so many endoscopic laparoscopists or endometriotic laparoscopic surgeon and fellowship. They are doing only on endometriosis, and I don't know how many endometriosis coming day by day. Even small, and I will show you the videos. There are small endometriomas that might be not be removed or it should be there, but people are doing because they know how to deal with endometriosis.
Yeah, so if I do a baseline scan and my endometrioma is lying on one side and I can see the follicles on the other side, or maybe only one or two follicles getting obscured, beginning of stimulation I'm saying, actually we can easily make out whether this person needs a surgery first, or we can, because we would want definitely, if IVF is possible first, then do the IVF first, do pooling of eggs or embryos, collect enough number and then go on to surgery. So even duration of infertility, as my co-panelist said, I don't think duration of infertility will decide that whether I have to operate her on or not. So it's purely
Because now patient did came to you because of so much of faith.
yeah, but
Somebody
then
else has explained of operation.
if
now
the
she doesn't
patient
go
is
to
coming
operation.
to me with severe pain, then obviously I'll have to think and give it a second thought. That patient may need a surgery first, and in that case a good counseling is needed, that every surgery is going to put an impact on the follicular count and on the AMH of the patient.
Yes, Varun.
So since we are talking about endometriosis only, I think it can never be an absolute criteria that you would not touch unless there are symptoms, because we have to understand that endometriosis itself can be a cause of infertility. And in my practice and your practice, you may see numerous patients after getting operated conceiving naturally. Right? So that also thought should be also be given.
With
Now-
simple diagnostic laparoscopy, they are conceiving.
Absolutely.
And on diagnoscopy, we will see that small endometrial nodules are that we are just.
And my other point, I would like to point that if you have done a cystectomy or endometriotic cystectomy, that does not mean that the patient is going to lose things forever.
No.
In fact, you may get lesser number of eggs, but there is a possibility your quality of eggs will be much better.
And you will get the eggs. Because
Absolutely.
with endometrium you can't
Because,
get eggs.
so-
Because we are not touching that ovary.
So always you have to balance that where you want to operate and where you don't want to operate. But I don't think there is any absolute criteria where you should not.
That is individual judgment. Yes, sir. You want to say?
No, I would differ. There is no difference in the quality of the eggs by removal of the
No, no.
endometrioma.
What Monica madam I am telling that once there is big endometrioma, 5 centimeter endometrioma, if you stimulate the uterus, if you stimulate the ovary, whether you are taking ovum from that ovary, yes or no?
Yeah, from both the accessible.
But suppose there is a 5 centimeter endometrioma,
Yeah.
how you expect that ovary will give you 1 or 2 follicles?
Yes,
No,
if it is hampering the pickup.
Then in this type of situation, if you remove
And
the
I agree, if it is a clean cut cystectomy,
Yeah.
the person is an expert,
Yeah.
then there should not be any adhesion or any problem.
Yes.
But invariably there is recurrence, even after the first child is born, there is a recurrence.
But madam, first child is born means the treatment
Prolonged
she has taken for
amenorrhea.
9 months.
Yes,
One of the
yes.
treatment of endometriosis is pregnancy.
And the best thing is she
Because
delivers
what we are
that child and
giving-
becomes
what we are
pregnant
giving the
again.
treatment is pseudoamenorrhea.
Best
So if
thing
she
is she
becomes
will-
pregnant, there are chances that she had already taken 9 months of treatment. Yes, madam.
It has to be very personalized based on,
Yeah.
that's the only way we can work.
Now, madam, this type of polyp is there, sir. Madam, yes, madam. Would you like to say this type of polyp should be removed?
Yes, definitely, sir. We have to see the blood flow, the size of the follicle, if it's
Yes.
obstructing the where we are going to implant our embryo. So it's a fundal.
It is a fundal fibroid.
It's a polyp.
It's a polyp. It's a very well visualized polyp
Yes.
with attachment over here. And if you put color, you will see vascularity also. And this type of fibroids we can this type of polyps we can easily remove with hysteroscopy. But if we know by ultrasound where is the vascularity, we will coagulate that vessel and then easily by millimeter by resectoscope. And nowadays we have got very good ultrasound morcellator is also available for this type of things. So you can use that ultrasound morcellator for removal of this type of polyp. It is very easy because they are using saline. If you want to use resectoscope, you have to use glycine, and glycine overload sometimes causing troubles in the early phase of TCR and everything. But
Bipolar resectors
So
also
bipolar,
available.
bipolar we can use.
bipolar we can use bipolar
Where with saline.
bipolar we are using with saline. So now technology has advanced, so we are able to remove this type of polyp and we can give very good result to our patients. Adenomyosis. Everybody wants to do. Suppose now we are talking just about the endometriosis. Now let's see. If suppose you will find this type of endometriosis over here. Okay, this type of endometriosis. This is just a routine diagnostic scoping. Sir, would you like to remove all this?
This endometriosis can be burned there.
Can be burned.
Locally, it can be burned there.
Okay.
And that's the treatment for it.
Sir,
And the patient can be any of this surgery, any endometriosis, even if it is a smaller endometriosis.
Yeah.
There is a unwritten dictum that whenever you operate on any endometriosis, the patient should conceive within 1.5 years.
1.5 years.
Otherwise, the endometrioma will become refractory.
Yes.
So we have to be energetic after this for a fertility treatment.
Fertility treatment. But it is everybody agrees that once you see this type of things during your routine diagnostic scoping, you don't let it be there. So now it is not a diagnostic scopy, we are always saying it is a diagnostic plus operative laparoscopy. And if we see this type of things we are able to remove, we can counsel that patient and these are the endometrioma. We are doing little bit extensive surgery because of peritonization and everything else. So, but everybody agrees. Varun, would you also like to do?
No, I just wanted to add up one point that rather than just ovulating, as rightly said, shown in the video,
Yeah.
you have to excise it,
Yes.
which will give you fantastic results.
Fantastic result. And now get very good. Now suppose I am just coagulating the tip of iceberg. Because there are so many deeper things. If you see this endometrioma I am removing, and you can see it is got very deep seated. But with this peritoneum, if I am able to remove this endometrioma, I will be very happy. Now next, without doing laparoscopy, without ultrasound, if you see this type of things, what you think that what it should be the likely? I had given vasopressin. All panelists have a question. What is this?
So it's a fibroid.
Fibroid. Monica madam? Fibroid.
Figo 5-6.
5-6 centimeter fibroid. Yes madam.
No, not Figo 5-6 stage.
Figo 5-6 stage fibroid. Yes madam. Sir?
This
Fibroid or
looks like
adenomyosis.
a fibroid, but
Yes.
can be also adenomyosis.
It's even adenomyoma, bigger one.
But can be adenomyoma also.
It can be, it is. So here your ultrasound helps.
Sure.
Here your ultrasound helps you to decide what is it. Same way we are doing the same exercise, we are doing giving vasopressin, we are cutting it with this harmonics, and you can see what peep out from inside. So here your ultrasound helps. This is adenomyotic nodule. It is adenomyosis, and we are doing adenomyectomy very well. It is the same patient in which we had removed all these endometriotic plaques. If you
But
see,
as you said rightly, that ultrasound is our stethoscope, and we should have done a pre-op evaluation, and her TVS should have been done
Yeah.
before this patient was taken up for a surgery.
so pre-operative ultrasonography, pre-laparoscopic ultrasonography help you a lot. Somebody might have written and it is a fibroid. Because if on ultrasound there is a specific differentiate between fetal for adenomyosis and fibroid. Fibroid has got peripheral vascularity, adenoma has got central vascularity. Adenoma has got all these cyst-like things. And now with adenoma surgery, people are benefiting a lot. Previously, people are not touching adenoma. They are there. But with this removal of at least two-thirds of adenoma, I am not removing 100% adenoma. I am keeping little bit tissue there to cover it up. And this patient become pregnant after this adenoma surgery. So this patient has got endometriosis external as well as endometriosis internal. So once you see this type of thing, always think that there could be adenoma, there could be fibroid, but your ultrasound will guide you that where you have to go, and this is a very good case in which we have got very good result. It's looking like fibroid, but it is not fibroid. Tubal surgery. How many of you are using ultrasound as a modality for tubal surgery? Once we have got very good earthquake, at that time there are so many tubal regularization we were able to do in Gujarat, and we found very good result. Ultrasound cannot give you the tubal linings, but it can give you the tubal pathology. Suppose there is a open cyst like this, suppose there is a hydrosalpinx. How many of you agree that if you see hydrosalpinx, you will do something or you won't do anything? Because hydrosalpinx, Monica madam, is causing infertility.
Hydrosalpinx is evidence-based that if you are putting a scope and you are seeing a diagnosed hydrosalpinx, you should always either clip or...
Either clip or you have to remove. But now patient has got one-sided ectopic, already tube removed,
Yeah.
second-sided hydrosalpinx.
Still you should, because there is evidence that hydrosalpinx fluid can
So
go
at
inside
that
the
time you have
cavity.
to dare and you have to tell patient that if we remove this tube, with IVF you can become pregnant. But if
Yes.
you don't remove the tube, even with routine treatment you are not able to become pregnant, and there are chances that you may get second ectopic in this type
You
of
have to
tube.
do good counseling before.
Also, the success rate of IVF improves by up to 30%.
Yes, yes.
This is a-
Because this hydrosalpinx is giving the material which is coming from that hydrosalpinx tube inside the uterine endometrium, they are hampering the uterine
Sometimes
endometrium
this
implant.
hydrosalpinx, it has got intermittent emptying into the
Yeah.
uterine cavity. It will fill empty. It will fill
Yes,
empty
sir.
repeatedly.
Yeah, I will just like to add that we have to be very vigilant in cases of multiple IVF failures.
Yeah.
Sometimes patients fail multiple times, come to you, always have a look at the tubes.
Yeah.
Because in good number of cases we find that it is the tubal swelling or the hydrosalpinx which was unaddressed, and after addressing it patient conceives. So looking at the tubes on ultrasound, as Dr. Monica said, sometimes it is intermittent. So I
Intermittent.
use this as an opportunity to document right there and then whenever you see it that yes, there is a
And
hydrosalpinx.
sometimes more infective tube or perisalpingitis.
Yes. And these tubes, you know, they are internally damaged. Their cilias are damaged. They're not going to give natural pregnancies to the patient.
Yes.
So very good counseling that yes, if the tube looks diseased, it should better be addressed rather than left.
Yeah.
Sir, other important, I think, rather technical point would be when to assess for hydrosalpinx.
Okay.
And I would say that you always look in the mid-cycle
Yes,
period,
fantastic.
because there is a high possibility if your patient is coming, you are always following on day 2, day 3, you would not be able to assess your hydrosalpinx, which would rather appear around day 13, 14, day 16. So always have an open.
One advice that once you are suspecting that after 3 cycle of ovarian monitoring, ovarian induction, patient is not conceiving, just see near to the follicle, rather than 2 vessels you are getting the 3 vessels. If you see this is the ovary, and if you see there is a follicle, but if you see third vessel like structure is also going, that might be your swollen tube.
Then put in the color flow and see.
And what
Yes, you
Dr.
will see the
Varun-
color flow. Yes, sir.
What Dr. Varun said, that we should evaluate at say around 16th day, also later,
Yes.
Later on also.
later on also,
At least
around
3 times.
25 day 25 or day 26.
It should be
Because
observed.
and once we have a cycle evaluated in 2 or 3 ultrasound settings, and if we don't find a tube swollen, then we can think that she does not have. But you are definitely going to find in the luteal phase
Yeah.
a hydrosalpinx.
So
Yes,
quickly, another technical point.
Yeah, yeah.
If you are looking at a persistent or a consistent hydrosalpinx throughout the cycle, and you are in a dilemma whether I have to remove this or not before you go for any kind of a therapy, you can always tell your patient to undergo an HSG test.
Yeah.
Because if your HSG is showing bilateral blocked tube, there is a high possibility you may not have to remove this.
Then we are coming
hydrosalpinx.
later, not HSG. We can do so
I
many things with
disagree
the
on this because if it is clear-cut hydrosalpinx and as you said persistent, if I push in dye, that dye may become static there and may give infection
May
to
give
the patient.
infection.
I will never.
So we have got
HSG
another motor.
surgery.
That question is coming. That question is coming.
I
So
just wanted to give a little message. I do a lot of observational studies on my scan when I have time. So sometimes with good high-end machines, you can see normal tubes also.
yeah, we
So
can.
mid-cycle, if there's little bit of fluid on in the peritoneal cavity, you see beautiful fimbria
Yeah.
floating. You can
So-
actually see the fimbria dancing in the fluid.
So why don't you put the fluid in the pouch of Douglas? Do
No, you
saline
can see during,
sonography.
you can see during ovulation only.
Ah.
Ovulation time will
Or
see
at the
number
time of
times.
ovulation, you can see free fluid is there. And naturally, whenever there is a ovulation, the fimbria is going there and fimbria is going to engulf this tube. At that time, the pressure was 2 to 4 millimeter of H2O, and fimbria is just sucking the ovum. Ovum is not going into the fimbria. Fimbria is going towards the ovum. You see, ovum can't move. Otherwise, ovum is moving our incubator from here to there. It is stationary. Just like all male and female, they are stationary because they have got two eggs. You see, they are stabilized. Why male is moving here and there? Because it has got Y. Only one limb, so he has to move. Joke apart. So this is adhesion mapping. Intraoperatively, how many of you has used ultrasound intraoperatively? Once you are in doubt, sir.
Intraoperatively, in histoscopic septal resection,
Yes.
we have used ultrasound. Like
You are putting one probe over abdomen and you are doing with, so you know.
Many a times we
So you are not over enthusiastically cutting the fundus of the uterus and going into the intra-abdominal.
Second is when we operate for ischemosy.
Ischemosy, yes.
That is another point when we require an ultrasound. These are the two main things.
So ischemosy you will use transvaginally.
Transvaginal.
In resection you are using transabdominal.
Ischemosy also transabdominally. When we are going through the histoscope,
Okay.
it is this, and also when there are adhesions.
Yeah.
When you have to have a patient with Asherman's or something, so at that time, initially while we have to put the sound, it is better to do an under ultrasound guidance.
Yes, fantastic. Anybody would like to add anything? So it will enhance your precision in infertility.
This is not a
surgery.
gynec thing, but I usually, whenever I do a modified Shirotkas
Yeah.
from, incompetent toss, I always do an ultrasound immediately after the stitch.
That is not.
Yeah, that just gives me the placement and it gives the satisfaction, the cardiac activity, everything is fine.
And nowadays everybody is doing laparoscopic, that is cause tightening. At that time also your ultrasound is helpful to look at the uterine vessels. So you are not ligating that uterine vessels. You have to go just medial to the uterine vessels and then you have to do the encirclage laparoscopically. So everybody agrees that ultrasound gives you very good precision in fertility enhancement surgery. Either you go in histoscopy or laparoscopy, ultrasound guided histoscopy, sir has rightly mentioned. And so many times laparoscopy guided or laparoscopy we have to use vaginal ultrasound to look at the fibroid, to know whether we are going in the proper plane or not, or whether we had reached up to the endometrial cavity or not. The fibroid is, our main goal is not to enter into the endometrial cavity, not to disturb the endometrium when we are doing the surgery. So ultrasound guided infertility procedure, egg retrieval, it is also coming. Everybody knows oocyte retrieval is very good. Everybody is doing oocyte retrieval by ultrasound. First oocyte retrieval was done by laparoscope. Because now we are celebrating 1978 Lucy Brown's birthday and we are celebrating this IVF Day or World IVF Day. The first oocyte retrieval was done through a laparoscope on unstimulated ovary, and from one center it has gone to the another center and they are fertilizing by Patrick step 2. But with the advancement of oocyte retrieval by transvaginal ultrasound, this procedure is very good. It will minimize your, we can measure the endometrial thickness, visualization is very good, assessment of ovarian blood flow. because once we are in doubt, we put that color Doppler. We can see whether this vessel we are puncturing or not, because we don't want our aspiration fluid contain blood clots. Otherwise, that blood clots will take the ovum inside. And then you have to do chopping and just become a Chinese to chop that blood clot, and you want to see the fertility. So predicting successful ovulation, also we are using ultrasound. We can also evaluate the ovarian function by Doppler ultrasound. How many of you are looking ovary differently with ultrasound? Yes, madam. How differently you are looking? Previously you are looking ovary, now you are looking at the ovary, ovarian volume, stromal volume, antral follicle count, how many follicles are there, the flow of the ovarian vessel as well as the follicular vessels. Everything you are mapping and everything you are writing before stimulating the patient. Monica, madam.
Yeah, now the Doppler can be really put into good use by fertility specialists. Number one, with due respect, Dr. Lula had spoken about the Applebaum scoring, but somehow I find even in a good receptive endometrium, sometimes you don't get those vessels reaching up to the zone 4.
Madam, for that you have to reduce your PRF.
Yes.
Otherwise,
Even if
reduction
sometimes
of PRF,
there is,
we can see every vessel is
yeah, so 0.3 kar do to everything is seen. But what nowadays we are following is the uterine artery PI.
Uterine artery.
Uterine artery PI less than 3 or less than 2.5, whatever is the cutoff.
On
With
the
a
day
good
of ovulation
endometrium,
or on the
on
day
the
of-
day of before the transfer.
Before the transfer.
Before
yes.
the transfer, if you get a PI of less than 3, less than 2.8, less than 2.5, that gives you confidence that you will be doing a good
So cutoff is 3.
transfer.
If it is more than 3,
3, yeah.
then
And
avoid
of
transfer.
course, the follicular vascularity.
Yeah.
More than 50 to 75% of the whole of the follicle covered with
Perifollicular
the
flow.
perifollicular.
We can call it as a perifollicular flow.
Yeah, and if you put Doppler in those, vessels at the peripheral, you will get a low level flow, and the PSV is more than 20.
Peak systolic velocity.
Yeah. So that also gives you a good idea. You can sometimes see the cumulus also.
Yeah. Cumulus furucus.
And that the signs of impending rupture of the follicle. You get some haziness inside. You get the appearance of the cumulus. You get crenation of the margin. And sometimes outside the margin, you get a double ring appearance. You get a halo of anechoic structure when the follicle is going to rupture.
So ultrasound is a must tool for IVF practice. Transvaginal ultrasound, during procedure, during pickup, post-transfer ultrasound has made our life very easy, because IVF is also one type of fertility enhancing surgery. Everybody is using embryo. Yes. Anybody want to add something? Yes, madam.
So apart from all the normal things which we see, whether patient is doing well, sometimes suddenly we start seeing echoes inside the follicle,
Yeah.
or the hemorrhages, and that is the time when we counsel our patients that maybe that the quality which is going to come out may not be good, or
Or
sometimes it may
luteinizing
be
and rupture follicular, LUF may be there.
Yeah, no, I'm talking about the IVF cycles.
IVF
before
cycles, but
retrieval
in
sometimes,
hello, we can
and
see
it this
that,
especially
that
happens.
may be empty follicle.
Yeah, this especially happens in patients with very low AMH, that
Yeah.
suddenly the follicle appearance starts becoming like a hemorrhagic thing.
Embryo transfer everybody is doing via ultrasound. Anybody refers that ultrasound is not needed. Ultrasound makes our job very easy.
Very easy. Only thing is, there was a workshop about 15 years back of transvaginal guided ET.
Yeah.
So I was very excited. I said, "Chalo, ye karte hain," because no need to put a full bladder there and just make the patient pass urine, go to OT, put a TV probe, and do your embryo transfer.
But
trust me, it's so cumbersome.
Cumbersome.
It is so cumbersome that I gave up after only 2 procedures.
How many of you are
Sir,
using
I'd
MIP
like
point?
to add one thing to Dr.
Yeah.
Monica, what she said. So I recently went to meet Dr. Ramaraju. He's in Andhra. So he's I've seen him doing it with so much excellence. He does it so perfectly. And when you talk to him, he'll be totally on transvaginal. And I've also seen somebody else practice. So I think it's more of what are you trained. So if you're perfect in doing a transvaginal, nothing like that. That is much better than a transabdominal. No thing of pressurizing the woman to have full bladder, that stress of, patient.
Nowadays, madam, we are not requiring full bladder. We are.
Earlier, Dr. Ramaraju used to do without ultrasound. He used to do without ultrasound.
Yeah. Even Dr. Jatin used to do without ultrasound. But how many of you are using MIP point? What do you mean by MIP point? maximum implantation potential point. We all know that we all fallen into the endometrium or ocean of the endometrium by this tubal ostia. The angle with this both tubal ostia meet, that is known as MIP point, and for every uterus, MIP point is different. Either for bicornuate uterus, unicornuate uterus, MIP point is different. And that MIP point you can judge at the time of pickup also. So this is fundus, here is the point, and you can map it out in your sheet that this is the way I have to go, this is my way from ostia to there, and here I will put my embryo. At the time of embryo transfer, you also decide that 1.1 to 1.5 centimeter I want to go below, and there ultrasound helps you a lot. If you put your embryo perfectly at the maximum implantation potential point, the success rate is very high. And nowadays everybody is believing in SET, that is single embryo transfer. Yes, sir.
The MIP point is good for day 5 or day 6 transfer,
Yeah.
but not for day 3 or day 2 transfer.
Why?
Because day 2 or day 3 transfer, the embryo will be moving. Because the embryo will not be at the same stage where because the endometrium is not ready at that time.
Okay.
The endometrium will be ready only on day 5 or day 6.
But nowadays, sir, everybody is going for blastocyst transfer. So
Sir,
it is,
if we transfer day 5, the implantation happens on day 7.
yeah.
So your embryo is still roaming around even after transferring a day 5 embryo. The whole aspect of MIP is that you are putting your embryo at a point where the nutrition and the media, or whatever you call it, is the maximum concentrated at that zone. And because of that, your implantation rate would increase.
That's why Varun, we are doing this with double sandwich technique. So embryo is moving. That's why we are putting that embryo in a double sandwich technique. So there is air, then there is media, then there is air, and then we are putting embryo. So that embryo is stuck between those two, and those two white dots are usually remain on ultrasound because this air, it doesn't going everywhere. The small droplets of air you can see over there, and that will restrict the movement of your blastocyst embryo, and that will stuck together. Okay, so there are different hysteroscopy, diagnostic endometriosis. Now only 8 minutes left. If suppose this type of cyst is there, Monica madam, would you like to operate? I will fix around 6:30. That time.
What is the ultrasound picture?
Ultrasound picture is endometriotic cyst.
So it depends upon the woman's age, her previous history.
She has got infertility, she has got dyspareunia, she has got dysphagia, she has got this jelly-like things, and there is a big endometriotic cyst like this.
But the right ovary appears normal.
So would you like to stimulate right ovary and wait for left ovary to be there?
No, now you have gone inside, it's better to, do a good surgery.
Yes, sir. Because I have been so better to operate rather than waiting.
It's always better to operate when you have put a scope and you see
Yeah.
picture like this, because you don't know what is going to happen next.
Yes.
And not every woman is for IVF.
Fantastic. So nowadays don't do diagnostic scopy, always do operative laparoscopy, and whenever you see any pathology that you are able to deal with, do it in a same sitting. Don't give them the option of going to somewhere else. Always first laparoscopy should be the best laparoscopy and should be the good laparoscopy for her. Yes, sir.
Sir,
I once again want to say that before going for a laparoscopy, please do pre-op transvaginal sonography.
Yes, you have to do. We have to.
And because then these things won't, you won't be in a dilemma. अभी क्या करना है?
Yes.
we always, while specifically about endometriosis and endometriosis operation, we always feel it has to be operated by an expert. Who is an expert?
Everybody is expert.
Everybody is
Those
expert.
who are doing the things, they are expert.
Now the thing is that nobody is born expert.
Yeah.
You have to develop
With
an
expertise, you
expertise.
can become expert.
Second thing is that it is not necessary that somebody who has done 100 cases is an expert.
No.
Somebody who has an experience of 5 cases but very sharp in a surgical skill can be an expert. So I would like to say that you have to have first of all confidence on yourself.
Yeah.
That you are able
Believe in
to
yourself, that you are able to do
able
this
to
thing.
operate. And if
So
not,
any cases like Varun, you can operate on all these patients. Even in a cases of endometriosis in the bladder, you can able to operate. So everything is can be done by everybody. Everybody is expert here. Everybody, those who have come on stage, everybody has got degree of MD or MS. They are expert dietitian, but you must know your limitation, that where my expertise lies.
Sir, the latest ESHRE guidelines also say that diagnostic laparoscopy is not the gold standard
Yeah.
for endometriosis.
Yeah.
So a good ultrasound and good imaging modality is good, and as far as Dr. Varun says that who's an expert. So I think it's
Everybody
a
is
great
expert.
amalgamation of a clinician and a surgeon, because surgeons usually are more interested in just cutting and chopping off everything, and I think as a clinician we have to tell them that it's a fertility sparing surgery rather than extensively just
When we
removing
see
all
this
the
type of things, we
endometriosis.
have to operate. We have to operate very carefully. We have to follow all the steps. We have got only 5 minutes left. So I am speaking all these cases. 3D ultrasound, Dr. Chandralula has rightly mentioned, it is very good because with 3D we can get the very good coronal plane that we are not able to see with 2D ultrasound. And sir, rightly you had said it is a virtual hysteroscopy. You can see both the ostia, you can see everything with transvaginal 3D probe. So 3D has got very good advantage over that, visualizing with very good anomaly. You can have a saline infusion sonography because only 4 minutes we are not going into this. But hycosi is very good thing, sir. You are doing hycosi, and sir has taught me how to see the tubes in hycosi. So we can see the tubes in ultrasound also. Post-operative surgical. Now, sir, new modality has made the name POCUS. POCUS. Point of care ultrasound. Now you see ultrasound is there in every ICC. You have to do ultrasound on the bedside, that is POCUS ultrasound, point of care ultrasound, and monitoring and healing outcome is very good. With ultrasound we can do sonosarcopography. Now those little bit audience are there. Yes, madam, there is question answer for you. Mike. This is not counting in me.
Paradigm shift in the management of this hydrosalpinx, because it was clipping or removal. But that is the sclerotherapy, that is aspirating hydrosalpinx fluid and putting 98% alcohol and sea. And in France especially, one or two countries actually they have switched to the sclerotherapy, because rightly we say not that like the patient tubal factor and we are clipping the tube, that has got a lot of psychological or some issues. So I want to have your expertise, your opinion about this sclerotherapy for management of hydrosalpinx before IVF.
Madam, I tried finding out the alcohol, okay, which is I was also quite
Fascinated by that
fascinated
paper.
by this, but it's not available in India.
It's not available in India.
No,
Just say that
madam.
it's
What
option.
happens, madam?
Ma'am, can I answer
Sclerotherapy.
this?
With
Can I
sclerotherapy,
answer?
you are not giving good life to the tube. Number one, all the cilia, everything has already gone. With putting another 90% alcohol, you are also damaging all the endosalpinx of that tube. So now, for the sake of tube is remaining there, because I had worked in Paris, so I know that there are too much of conservation. Even in primary, they don't want episiotomy. So they are too much conservative. So they see that tubes are there, but now these tubes are on the sake of tube. They are, because after putting sclerotherapy, that tube is, which is 80% dead, now it is 100% dead.
So I think, ma'am, for your question, there is a lot of counseling which is needed for all these patients where we are anticipating anything to be done on tubes. And this is something which we really, give a lot of importance as fertility specialists when our patients are not conceiving and we are going to going for laparoscopy for some other reason and simultaneously testing the tubes, and there is a doubt of hydrosalpinx or anything. Because you have rightly said that there is a lot of emotional sentiments which do come in between, and patients, in spite of the fact that they are shown on the ultrasound that the tubes are grossly swollen, even then they will ask, if you clip my tubes, will I be able to conceive naturally? So a lot of counseling that these tubes, even if we leave them behind, they are not going to help you, they are not going to, because they are not practically functional. So I think here the counseling plays a main role, and we have to see laparoscopically once we are in whether we have to do self-injectomy or clipping.
Madam, if you are doing an ultrasound guided sclerotherapy, then you can do it. But if you are putting a laparoscope, there's no point of it. Yeah, so that is one. And second thing is, the only risk factor in sclerotherapy is that it catches infection so fast. So you have to be careful about giving good post or procedure antibiotics to this patient. That's it.
Now little bit rapid question.
I have a question
Yes.
also, since sclerotherapy was started as a topic. So endometriomas.
Yeah.
So IVF, before
Before
IVF,
IVF,
suppose.
just aspirate the endometrium and put alcohol inside.
Yeah. So that is the question. So how many of in the audience as well as the panelists, practice this? It is against the guidelines which they say you should not do it, because I have seen people doing it. So I have
Madam,
this question.
I had seen, I had done it, and ultimately I had stopped it. Can I say something? Because it doesn't give me any benefit. Number one, just I am aspirating the endometrioma by our worm pickup needle, then flushing it with 90% alcohol. The rest of the damage, they also like alcohol. The rest of the worms, they also like alcohol. So they become alcoholic, and they don't give me the result after what I want. So it doesn't do. Now
But
just
Manish-
rapid, yes.
Manish, can I say?
Yeah, अरे दादा बोलिए.
We do for endometriosis, but not for fertility patients.
Post fertility, because now that ovaries is become little bit questioned. Because of that, what is the purpose of putting 90% alcohol?
No, we put methotrexate.
Methotrexate, okay. But that methotrexate also gives you the destroying of that wall. So now there will be some post. Those patients don't want to go for hysterectomy. For this type of patient, this is a good thing. Now there is a few questions. Varun, concentrate on it. Varun. Now there are few questions. I am just reading that questions. Only 5 minutes are there. Which ultrasound finding is most predictive for successful undergoing controlled ovarian stimulation? Anybody can answer. 1, 2, 3, 4. Not able to visualize? Okay.
Dominant follicle.
It is dominant follicle. Okay. Now, how does 3D ultrasound improve the assessment over 2D ultrasound? Chandralula has rightly mentioned. Which things you can get good? Enhancing the visualization of the uterine cavity. Fantastic. In patient with suspected endometriomas, which specific ultrasound feature is highly indicative of ovarian
Homogeneous ground glass.
Third point.
Very good. Homogeneous ground glass ecosity. What is the role of color Doppler plays in evolution of ovarian function during infertility treatment?
Third. All
3.
Evaluating blood flow in the ovarian vessels. Which ultrasound marker is most commonly used to assess the ovarian reserve in infertile woman?
AFC.
Everybody knows AFC. During hysterosonography, saline infusion sonography, what findings is indicative of intrauterine adhesions like Asherman syndrome?
Irregular filling defect.
Irregular filling defects with uterine cavity. Our all panelists are very expert. What is the significance of detecting lead follicle during follicular monitoring ultrasound in ovarian cycle, ovarian induction cycle?
Impending ovulation.
Suggesting impending ovulation. So we can know that now we have to go a little bit faster.
I think these should be for audience, whether they
Madam,
have
audience are, yes, if now these two questions are for audience. What is the role of ultrasound in assessing tubal patency in infertility investigations? All audience either are talking or sleeping. Yes, sonosalpingography. No. ICOC. ICOC is giving you the very good assessment of the tube through ultrasound. In contrast of infertility, sorry, which ultrasound finding is most consistency with hydrosalpinx? Audience.
2.
Fluid filled dilated fallopian tubes. Last questions. In patient undergoing IVF, how ultrasound is guiding in oocyte retrieval? Everybody knows. By visualizing and estimating follicle through transvaginal. So thank you very much. Main need is difficulty because you want to progress, said by Abdul Kalam. And thanks that every company are using dydrogesterone paper of mine. And lastly, everybody should be happy. Please start the audio.
Sir, one question, last question.
Yes.
When you are hydrocephalus, which are not CPLs or which are we are stimulating, this also swells. I think all our IVF specialists have noticed this point. When you stimulate with hormones, that's also responding to the tubes, and they are that time.
At that time, tubes are swollen.
Yeah, you can. I know I had some that time. Then you can do after that counseling and removal before IVF.
That's we can do. Please give me the audio. So ultimately, end of the day, everybody should be happy. Audio.
And the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right.
This is very good nursery poem.
The time to be happy is now. And the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right.
Thank you very much. Thanks my all panelists. So
Thank you, sir. Wonderful moderation, I think.
Thank you.
We as panelists, all of us enjoyed.
Thank you. We can have a group photo, please. Yeah.
कितने फोन है यार